All right, so today we're going to be discussing and investigating episodic vestibular syndrome, or EVS, and its components of rehabilitation. So firstly, we're going to be discussing the pathology. So EVS is a condition characterized by recurrent spontaneous episodes of dizziness that range in duration. The majority of attacks last from minutes to hours. So EVS can be triggered, but it is mostly idiopathic, and it is characterized by acute dizziness, gait instability, nystagmus, and particularly head motion intolerance. Usually patients experiencing this dysfunction experience particular comorbidities, including things like Meniere's disease, vestibular migraines, and/or reflex syncope, also known as fainting. However, more sinister central pathologies, including things like cardiac dysrhythmias, unstable angina, or TIAs, or transient ischemic attacks of the posterior circulation, they can disguise themselves as EVS. The most sinister pathology, TIAs, is usually exhibited due to vertebral and/or basilar artery stenosis, resulting in transient occlusion of the vessel and repeated episodic and isolated vertigo. During the HINTS clinical examination, nystagmus may present itself as a central or peripheral pathology. However, it may also present itself as absent, not being there. This mixed pathology is evident with our patient as he exhibits nystagmus during primary gaze, which is indicative of a central pathology. However, upon gaze evoked and smooth pursuit, he exhibits unidirectional beating towards the left, which indicates a right peripheral hypofunction. This condition, when assessed using a head impulse test, is usually manifested with a unilateral abnormality when the head is moved towards the affected side. In this case, our patient has performed a corrective refixation saccade when the head has been moved to the right, indicating a right peripheral pathology. Patients experiencing episodic vestibular dysfunction typically experience worse dizziness with head movement. This is particularly noted during the Dix-Hallpike maneuver, where the head moves significantly. Our patient experiences severe dizziness bilaterally and must close the eyes and cease testing as it's far too uncomfortable. Although the patient does experience dizziness during the Dix-Hallpike test, it does not necessarily indicate a different pathology like BPPV. Patients experiencing EVS are usually seen to stand and walk with nil abnormality, which is evident in our case. So Steve doesn't present with any type of gait or standing abnormality when the eyes are open. However, when support conditions are changed and the visual input system is occluded, the somatosensory and vestibular systems become inaccurate, resulting in poor coordination and instability evident with Steve's results.
Okay, so treatment may include a combination of medication and physiotherapy. A few limited cases may require surgical treatment. Before the treatment has begun, the patient should be informed that the prognosis is generally positive, varying from a few days to a few weeks. Many of these conditions have a favorable spontaneous course, both because peripheral vestibular dysfunction tends to improve and because there is central vestibular compensation for asymmetrical peripheral vestibular tone. Moreover, most of these conditions can be treated conservatively successfully. The patient should also be educated about the etiology of EVS, things to do at home to decrease symptoms and improve daily activities. Looking at treatments, we first have medication. Acute phases can be treated with the infusion of corticosteroids, electrolyte substitution, antiemetics, and vasodilation medication. We also have physio, which includes exercises that focus on the adaptation of the VOR, gaze stabilization exercises to help improve the coordination of head and eye movements, and walking exercise to improve balance in challenging environments such as outdoors, uneven surfaces, dimly lit rooms, and crowded places. We'll go into more detail about each of the relevant physio interventions next.
In order to prescribe exercise, we use substitution, habituation, and adaptation exercises to target the impairment and dysfunction for Steve. So in regard with the substitution, there's a two exercise which will, first exercise will able to fix saccade and VOR dysfunction, and other exercise will target imagery pursuit. So exercise one, which involve saccade and VOR dysfunction. In this exercise, we set up 3 targets on the right side of the patient. So first target will be aligned with the head, right straight front, and then second target half a meter away on the right, and the third target further away half a meter. So we instruct the patient to look directly at the target 1, ensuring that his head is aligned with the target, and then look at the target 2 while keeping the head aligned in the first target, then follow the target 2, then look at the target 3, keeping head aligned with the target 2, then followed with the head movement to target 3. So as I said, this exercise will target saccade and VOR. And this exercise requires 1 minute twice daily. So next exercise, which target imagery pursuit. In this exercise, we also set 4 targets on the right side. But in this exercise, we tell the patient to look directly at the target 1, ensuring that his head is aligned with the target. And then we tell him to close the eyes, slowly turn the head away from the target 1, and imagining that he's still looking directly at the targets 1, 2, 3, and tell him to follow all the way up to target 4, and then open their eyes and check if whether they have been able to keep their eyes on the target or not. They had to adjust, and the gaze was there on present on the while they were on the target 4. So this exercise also require 1 minute twice a daily. Now we're going to move on to habituation. So in this exercise, we broke down lying to stand up exercise in 2 components. First one was lying to sit. In this exercise, patient Steve has to sit with leg extended, head upright, centered, slowly lie on the back without a pillow and maintain position until the symptom subsides for 5 to 10 seconds, and then followed up with sit up slowly and maintain the position until symptoms subside for 5 to 10 seconds, which he has to perform 1 minute twice a daily. The next component of habituation exercise is sit to stand. So in this exercise, Steve has to sit on the edge of the bed of the chair or the bed or the chair, and feet under the knee and shoulder width apart, head upright and centered, stand up slowly and maintaining upright posture until symptoms subside for 5 to 10 seconds. In order to maintain balance, this exercise should be performed next to the wall, or this should be a chair. And this exercise requires 1 minute twice a daily as well. So next we're going to move on to adaptation. So this exercise involves gaze stabilization exercise, which will target VOR dysfunction and gait stability. So in this exercise, which involves to focus on a target at eye level, which is aligned with the center of the body, while walking backward and forward across the room, simultaneously slowly turning the head to the right, to the left, while keeping the focus on the target, which was straight ahead with the center of the body. So this exercise has to be performed next to the wall, but only touch the wall if there is a loss of balance and feeling dizzy, or there's a sign and symptoms of vertigo. And this exercise need to be performed 1 minute and twice a daily. Now I'm going to hand over to Kostul.
Oh, sorry. So the principle behind substitution is that we want to have the vision and somatic sensation accommodate for the decreased vestibular function. Essentially, we want to get the function of the eyes accustoming for the reduced vestibular function. So first exercise is a corrective saccades, which will allow the patient to regain control, regain active control of what he has. And second exercise is enhanced mood pursuit. This will also substitute for the deficient vestibular ocular reflex, and it's going to be a bit more meaningful for the patient because the patient does want to get back to boating and get back to fishing, which will incorporate the part where he needs to be able to focus on an object and follow it in a smooth line motion. Basically, it's going to allow him to regain active control of his eyes and have the balance aspect in the deficiency of the vestibular function. Habituation, on the other hand, will expose the patient to provocative symptoms, and the patient has trouble getting out of bed. So that's why you want to focus on rolling in bed, supine to sitting out of bed, and also sit to stand. The function of habituation is that you're exposing the patient to a very provocative stimuli in an attempt to build tolerance to it, and also reduce or desensitize the patient to that factor. Essentially, you want to push him to where his threshold is and try to gain active control within that, not going too far into extreme, just within that threshold. Adaptation, on the other hand, adaptation is an incorporation of substitution and habituation, where the patient is trying to do more functional tasks like gait stabilization during walking and during multitasking, where he has to use the remaining vestibular ocular reflex, that is, or vestibular function that he has, but also substitute other factors like somatic sensation, to feel around, have few cues for him to regain this balance. For example, when he is walking, he can always grab onto the wall if he's losing balance. and essentially build that tolerance to that to balance. And this will be more meaningful for him because he wants to get back to walking normally and reduce his symptoms of dizziness and vertigo. Also, the patient does want to get back to normal baseline function very soon. So we want to have a high dose, high rep, a bit more intensive for him. So, but still remain at that threshold. But yeah, high dose, high rep to allow him to get better much faster. Other things we need to consider for the patient is that he wants to improve his gait and 6% function. So we want to focus more on those multitasking and adaptation exercises. He wants to get back to fishing and wants to get back to boating. So needs pretty good balance for that. In regards to that, has to be intensive so he can get back to it also pretty quickly and accommodate with his vision and somatosensation where he cannot take over with his vestibular function. Patient wants to mobilize more and generally get back to his baseline function. So we want to tailor his exercises to that.
So since the patient is experiencing episodes of vertigo during various activities, such as mobilizing in bed or shopping, implementing an exercise-based vestibular rehab program would be necessary in order to treat the vestibular system. So utilizing the principles of adaptation, substitution, and habituation will hopefully allow him to manage when he does feel those bouts of vertigo. So according to Clendaniel 2010, adaptation exercises are situated on the ability of the vestibular system to modify the VOR in response to head movements. So according to Al-Ghadir, adaptation exercises have also been found to improve postural stability during these episodes of vestibular disequilibrium. And so as such, practicing gait stabilization exercises would hopefully modify the magnitude of Steve's VOR, hopefully getting his vision to be more clear and stable when he is doing those aggravating head movements. So adaptation exercises are also often the first strategy implemented by physios to manage complaints of dizziness. So this vestibular adaptation exercise would serve significantly to improve Steve's symptoms, balance, stability, and quality of life.
Habituation is a modality of vestibular rehabilitation that emphasizes repetitive exposure to provocative maneuvers to induce vertigo. So this movement allows the patient to acclimate themselves to the symptoms of vertigo and better adjust during these episodes. According to Hahn et al., habituation desensitizes the response to repetitive sensory stimuli due to repetitive exposure. So by prescribing exercises based on functional activities, which reproduce Steve's vertigo, it would enable the vestibular system to adapt and decrease his complaints of dizziness. Implementing these types of exercises would allow Steve to return to his regular activities, such as fishing. Finally, we have substitution. Now, this principle focuses on increasing the patient's reliance on visual and somatosensory inputs to compensate for his decreased vestibular function. This resulting compensation leads to a significant improvement in postural stability. According to Hahn, the goals of substitution for postural stability includes educating the patients to utilize stable visual references and somatosensory information in order to appreciate the body's posture and positioning when experiencing bouts of vertigo. Additionally, this increased input would reinforce their remaining vestibular function and aid in developing alternative postural strategies. With the prescription of substitution exercises, Steve would be able to appropriately utilize his visual and somatosensory systems, allowing him to adjust accordingly during episodes of vertigo, and will decrease the complaints of disorientation and sensation of falling. These improvements will greatly contribute to the patient's quality of life and return to normal function.
Okay, now the questions. In regards to question 1, a study by Ole et al. Reported that the HINTS exam has a sensitivity of 97% and specificity of 95%. The HINTS exam has a high sensitivity, which refers to its ability to correctly rule in diagnosis and identify patients with the pathology. Additionally, the exam reports high specificity and is thus able to correctly rule out patients without the disease. Hence, the HINTS exam will allow therapists to correctly identify the patient's condition while knowing the results achieved by the test is valid and true. Over to you, Otava.
Yeah, so looking at the second question, the HINTS exam involves three components which are used in order to differentiate whether the patient's displaying symptoms associated with central or peripheral dysfunction. The first component of the HINTS exam is the head impulse test, which assesses the integrity of the VOR. If the patient is able to maintain fixation on the assessor's nose when rotating the head quickly, this is considered a negative result, and when showing signs of dizziness, indicates central dysfunction. Alternatively, a positive head impulse is a sign of a peripheral dysfunction. The second component is nystagmus, which is the involuntary ocular movement in which the eyes beat towards a certain direction. The movement includes a slow and fast phase, with the fast phase occurring opposite to the lesion. For central dysfunction, nystagmus is displayed bilaterally as well as disassociated nystagmus, whereas with peripheral nystagmus, it will beat towards the unaffected ear. The last part of the HINTS exam is skew deviation, in which the patient is instructed to fixate on the assessor's nose as one of their eyes is covered, after which the cover is removed and applied upon the other eye. Peripheral dysfunction is usually indicated with eyes remaining motionless during the test, which is positive, and central is associated with a refixation saccade, which is negative.
Okay, and the last question, a study by Bayat and Saki observed the effectiveness of the vestibular rehabilitation exercise program in a group of elderly patients aged 61 to 74 with unilateral vestibular hypofunction. The majority of the patients experienced high levels of dysfunction and disability at the start of study, and their symptoms were reduced to mild level of impairment by the end of the study period. They concluded vestibular rehabilitation technique, VRT, is an effective method for the management of elderly patients with episodic vestibular syndrome and shows maximal effect on the functional aspects. Dizziness handicap inventory was used before and after the treatment, which resulted in an average decrease in DHI score of 25.98 points after 2 weeks and 32.54 points at the end of the study. This indicates that the first 2 weeks of intervention was the period in which the intervention plan had the most beneficial outcomes compared to subsequent 6 weeks. As such, vestibular rehabilitation may have a potential element of diminishing returns in the amount of progress expected. Hence, with these results, we are confident that the VRT consisting of substitution, habituation, and adaptation develops postural stability in patients with unilateral vestibular dysfunction and will have a positive effect in improving gait as well as quality of life while reducing symptoms of dizziness, depression, and anxiety. And this is the end of our presentation. Thank you for watching us.